Hello everyone, my name is Jorge Acosta. The topic is systemic therapy for metastatic renal cell carcinoma. Presentations. This is my name, my information about my social networks. Definitions. Introductions. Renal cell carcinoma can spread from a mass of cancer cells of tumor to other parts of your body. This process is called metastasis. It occurs in one of three ways. Cancer cells spread into the tissues around the tumor in your kidney. The cancer moves from your kidney into your lymph system, which have vessels throughout the body. Kidney cancer cells enter the bloodstream and are carried and deposited to another organ or location in your body. This is the video about the explanation of renal cell carcinoma.
Learning medicine is hard work. Osmosis makes it easy. It takes your lectures and notes to create a personalized study plan with exclusive videos, practice questions, and flashcards, and so much more. Try it free today. Renal cell carcinomas, or RCCs, are the most common type of malignant kidney cancer in adults, generally affecting older men. Unfortunately, RCC is often considered a silent cancer because symptoms don't typically get noticed until the tumor has grown pretty large. Renal cell carcinomas form from epithelial cells in the proximal convoluted tubule of the kidney. And this is the section of the nephron that's usually located in the renal cortex, the outer rim of the kidney. The most common type of renal cell carcinoma is composed of polygonal epithelial cells, which have funny angular shapes with at least 4 sides, and are filled with clear cytoplasm full of carbohydrates and lipids. And it's those lipids that give the tumors their yellow color. At a genetic level, renal cell carcinomas have been linked to mutations on the short arm of chromosome 3, or 3p. An easy way to remember this is that RCC has 3 letters, and it's linked to chromosome 3. One of the main genes involved in renal cell carcinomas is the VHL gene, which codes for the von Hippel-Lindau tumor suppressor protein, or PVHL, which is normally expressed in all tissues. Mutations in PVHL can allow IGF-1, the type 1 insulin-like growth factor, pathway to go into overdrive. And this does 2 things. First, there's dysregulated cell growth. And second, it upregulates specific transcription factors called hypoxia-inducible factors, which in turn generate more vascular endothelial growth factor, or VEGF, as well as VEGF receptor, leading to growth of new blood vessels, or angiogenesis. Dysregulated cellular growth and angiogenesis are a recipe for tumor formation. Renal cell carcinomas can arise sporadically, or they can be part of an inherited syndrome. Sporadic tumors are usually solitary tumors in the upper pole of the kidney, and most often happen among older men that smoke cigarettes. Inherited syndromes, like von Hippel-Lindau disease, can also give rise to renal cell carcinomas. In this situation, the tumors typically affect younger men and women, and often involve both kidneys. Von Hippel-Lindau disease is a rare autosomal dominant disorder characterized by a mutation in a tumor suppressor gene, which leads to the formation of cysts and benign tumors in various parts of the body, like the eye and central nervous system. The number 1 cause of death in patients with von Hippel-Lindau disease, though, is the development of renal cell carcinomas. Individuals with renal cell carcinoma typically have one or more of the following symptoms: hematuria, or red blood cells in the urine, which is most common, a palpable mass in the abdomen or lower back, and pain in the flank or near the hip bone. Since the cancer causes a state of chronic inflammation, other classic symptoms include fever and weight loss. Renal cell carcinoma is also frequently responsible for causing various paraneoplastic syndromes, which is where the tumor cells generate a hormone that causes its own set of symptoms. For example, these tumors can release the hormone erythropoietin, which increases the production of new red blood cells. And this can lead to polycythemia, or too many red blood cells, which can cause the blood to start sludging or slowing down its normal flow. Another paraneoplastic syndrome involves the release of renin, a hormone that's part of the renin-angiotensin-aldosterone system, and is involved in raising blood pressure. Some other hormones that renal cell carcinomas are known for releasing include parathyroid hormone related peptide, or PTHRP, which causes hypercalcemia, and adrenocorticotropic hormone, or ACTH, which increases release of the stress hormone cortisol and can lead to Cushing's syndrome. Finally,
This is the video about the case review.
This is a 49-year-old male who was previously healthy, and he presented to an emergency room with complaints of abdominal pain. He had an evaluation done by CT scan in the emergency room that showed that he had diverticulitis, which was likely to cause the abdominal pain, but he was found to have an 8-centimeter left renal mass that was found incidentally. The patient was referred to a urologist and had a complete workup, which included a CT scan of his chest, abdomen, and pelvis, appropriate blood work and a urinalysis, and he underwent a left radical nephrectomy. The left radical nephrectomy was performed in September 2015, and the results showed that this was a clear cell carcinoma, a stage PT2A. The Furman grade was 3, and a node dissection showed that there was no spread to the nodes. At that point, CT imaging of the chest showed no evidence of metastasis, and he was considered to have stage 2 clear cell carcinoma of the kidney. The patient was followed with serial imaging studies by the urologist, and in September 2017 was noted to have a local recurrence in the bed at the site of the nephrectomy, as well as a large lytic metastasis in his pubic bone. Further imaging showed multiple pulmonary metastasis. He was referred to a medical oncologist who continued the evaluation, and blood work, performance status, and other serologic tests showed that the patient was anemic, had normal calcium, had an adequate performance status of 90, and was considered to be intermediate risk by both MSKCC and international criteria. The medical oncologist started the patient on sunitinib on the standard 4-week on, 2-week off schedule. He tolerated therapy relatively well, initially having hypertension, which required implementation of antihypertensives. He also had some hand-foot skin reaction, which was managed by topical lubricants. The patient achieved a partial response to sunitinib with a stable bone disease, but good response in both the lung metastasis and in the local recurrence in the left kidney bed. He was continued on the sunitinib until July 2018, when he was noted to have additional pain in the pubic bone, and the imaging on treatment with sunitinib showed that he had progression in the bone, the retroperitoneal mass, and new lung metastasis as well. At that point, the medical oncologist restaged the patient with a full CT scan, chest, abdomen, and pelvis, with appropriate blood work, and he was deemed to be intermediate risk by MSKCC criteria based on anemia, but with a normal calcium and a performance status at that time of 80. There were several treatment options that were considered at the time, including axitinib, nivolumab, and cabozantinib. The treating oncologist chose lenvatinib everolimus and initiated systemic therapy with those agents at that time as a second-line treatment.
Application in medicine. Sunitinib and pasunabib are approved treatments with first-line therapy for patients with fatal or intermediate-risk clear cell RCC. Desirolimus has proven benefit over interferon alpha in patients with non-clear cell RCC. In the second line, treatment, the TKLS or mTOR inhibitor are treatment choices. Therapy options after TKI failure consider everolimus and axitinib. Available third-line options consist of everolimus and sorafenib. Recently, nivolumab, a programmed DEAD1 checkpoint inhibitor, improved overall survival benefit compared to everolimus after failure on one or two VEGFR-targeted therapies, which is likely to become the first established checkpoint inhibitor in MRCC. Data for the sequencing of ICANN remain limited. The next is the other video about the new diagnostics.
Hello, and thank you for joining this OncLive peer exchange titled Evolving Treatment Paradigms for Renal Cell Carcinoma. The standard of care for patients with metastatic renal cell carcinoma continues to change rapidly as novel therapies and combinations have gained recent FDA approval. The busy oncologist treating a patient with metastatic disease now has a plethora of choices for both newly diagnosed and relapsed kidney cancer. In this OncLive peer exchange, my colleagues and I will look at the challenges in finding the right systemic treatment for the right patient. We'll talk about the data from ASCO 2018 annual meeting and how it relates to the treatment of advanced disease. I'm Dr. Daniel George, and I serve as Director of Genitourinary Oncology at the Duke Cancer Institute in Durham, North Carolina. Participating today on our distinguished panel is Dr. Robert Armato, Professor and Chair of Oncology at UT Health McGovern Medical School and Chief of the Division of Oncology at the Memorial Hermann Cancer Center in Houston, Texas. And Dr. Tony Shuari, the Lang Center for Genitourinary Oncology at Dana-Farber Cancer Institute and Professor of Medicine at Harvard Medical School in Boston, Massachusetts. Dr. Richard Joseph, an Assistant Professor of Oncology, Division of Hematology Oncology at the Mayo Clinic in Jacksonville, Florida. And finally, Dr. Walter Sadler, Professor and Chief of Hematology Oncology in the Department of Medicine at the University of Chicago in Chicago, Illinois. Thank you so much for joining us. So let's begin. So starting out, gentlemen, with newly diagnosed metastatic renal cell carcinoma, there have been a couple of new approvals this past year now for the treatment. Tony, do you want to walk us through cabozantinib and the CABOSUN data and how that's kind of led to its new approval?
Absolutely, Dan. So we launched with Alliance and Nash Cancer Institute. You are part of this, a randomized phase 2 to ask the question whether cabozantinib is superior to sunitinib, a long-standing standard of care in renal cell carcinoma. Premise that cabozantinib target VEGF receptor and other receptors involved in resistance to VEGF inhibitor. We focus on an intermediate and poor population with the primary endpoint of PFS, progression-free survival, was met, both by investigator assessment and independent review, and based on that, cabozantinib was approved by the FDA as an option for untreated patients.
Right, and that approval, talk a little bit about that approval, just a little bit broader than what the actual study looked at.
Correct, and we see that approval different sometimes from the FDA to the European agencies. It was approved on all risk groups, despite the evidence. The CABOSUN data did not include patients with good risk, and essentially these patients were clear cell component. There is emerging data in patients with non-clear cell component, and I think though the train have left the station because cabozantinib is being now explored in combination with other drug, including immune checkpoint inhibitor, like our planned study, again, from Alliance, the pedigree study.
We're going to get to that, but Walt, I want you to weigh in here now. Does the CABOSUN data and the new approval of cabozantinib, does that change your practice in frontline metastatic RCC?
I think it does a little bit. I think that it becomes, for me, another option I think, though, that we have to recognize that this was a randomized phase 2 study with a progression-free survival as an endpoint and not an overall survival endpoint. And so we see some improvements in progression-free survival. Whether that actually translates into overall survival, I think, is unknown. It is a reasonable intermediate endpoint, but not a perfect intermediate endpoint. And I think I have a little bit of concern with the broad approval for all prognostic groups, because this trial did not include patients with good prognosis disease. And we do have to keep in mind issues of toxicity, where we have, for example, a trial that compared pazopanib versus sunitinib, in which there was an improvement in tolerability in the pazopanib group across a broader range of patients.
Fair enough. Efficacy versus tolerability, it's a balance, right? And
Correct.
we're going to weigh both of those, particularly depending on the patient population we're looking at. And we're going to get into patient selection in a little bit. Any thought, Rich, from your perspective on, and I know that you're newer to the field with this, in this field, but sometimes fresh eyes give a new perspective. What are your thoughts on Cabo-Sun, and have you used that in the frontline setting?
Yeah, thanks. I think cabozantinib is a very great drug. I think beating out sunitinib with PFS at least shows us that it has at least equivalent, if not better, activity in those groups of patients. I do agree with Walt that the toxicity for me, in my hands, does seem to be a bit worse, especially at the initial dose of 60 milligrams. I tend to start patients at a lower dose, and I think it certainly, building off of that from the COMPARE study, probably is more toxic than Votrient as well.
This is the video about the treatment.
Welcome to our treatment for metastatic stage 4 kidney cancer quick guide.
Cancer treatments can be divided into two types: localized and systemic. Surgery and radiation are localized treatments. They remove or kill the cancer cells in or near the kidney. Chemotherapy, targeted therapy, and immunotherapy are systemic treatments. They kill cancer cells that might be anywhere in the body. About 16%, or 16 out of 100, people with kidney cancer are diagnosed after their cancer has already spread or metastasized to other parts of their body. This is called stage 4 kidney cancer. In other cases, the cancer recurs or comes back as metastatic after initial treatment. In some rare cases, if you have not previously had surgery and only have a few metastatic spots, your doctor may recommend that you have the kidney removed along with any metastases that are near the kidney. Whether or not you have surgery, your doctor will recommend a systemic treatment.
Targeted therapies and immunotherapies are used to treat metastatic kidney cancer. Your doctor may recommend one drug or a combination of drugs. Targeted therapies can be given as pills you take by mouth or as an IV into your vein. Some targeted therapies work by blocking the growth of the new blood vessels tumors need to grow and survive. Others target specific proteins that help tumors grow. Immunotherapies are given as an IV into your vein. These drugs help your immune system see and kill cancer cells.
Every drug used to treat kidney cancer has its own specific side effects. Ask your healthcare team about which side effects you should let them know about right away. Common side effects of targeted therapy include skin rashes, tiredness, nausea, diarrhea, mouth sores, pain and swelling in the hands and feet, and high blood pressure.
Immunotherapy drugs work by getting your immune system to kill cancer cells. These treatments are given as infusions. Common side effects can include flu-like symptoms like fever, chills, headache, nausea, and cough, fatigue, feeling tired, skin problems like rashes, redness, or itching, and muscle or joint pain.
Less often, the side effects may be severe or even life-threatening. Ask your doctor about what you need to watch out for. Tell your healthcare team immediately if you have diarrhea, problems breathing, eye problems, stomach pain, cramping, nausea, vomiting, fever, sudden changes in energy or severe weakness, headaches, chest pain, decreased urination, that's peeing less, and or problems thinking or remembering things. If caught early, these more severe side effects can often be managed with steroids. You can learn more about immunotherapy on the Cancer Support Community's website, www.cancersupportcommunity.org/immunotherapy.
A risk stratification tool has been developed to help doctors determine treatment options in patients with metastatic kidney cancer. One widely used tool, called the IMDC, looks at whether or not you have these risk factors: a low red blood cell count, or anemia, a high white blood cell count, or neutropenia, an elevated platelet count, or thrombocytosis, high calcium levels, or hypercalcemia, difficulty taking part in daily activities, and it's been less than a year since your kidney cancer diagnosis or initial stage 4 diagnosis. The IMDC is scored like this: 0 factors, good risk category; 1 or 2 factors, intermediate risk category; 3 or more factors, poor risk category. The score helps your doctor determine if the risk of symptoms and side effects outweighs possible benefits from treatment.
Pros. This is now the mainstay of renal organ support in critical condition, has our understanding of CRRT delivery and its impact on patient outcome improved. There is a focus on investigating the potential benefit of treatment the specific patient tailored to the dynamic needs encoding. CRRT dosing, teaming, fluid management, membrane selections, anticoagulations, and vascular access are reviewed. The most recent study today investigating aspects of CRRT prescribing that can be individualized. Cons. In certain patients, the treatment is effective, but in others, it is not. Treatment is expensive. In some countries, they don't know about that or don't have sufficient resources for this treatment. It can cause problems in other organs due to the adverse reactions that the patient may present. And the cure rate is low with this therapy if the carcinoma is in final stage. This is a bit about the manage on 3.
Dr. Paul, let's turn our attention to kind of systemic therapy. Patient walks into your office, they have metastatic disease. You have to determine kind of their prognostic variables based upon their clinical parameters. You're going to have a conversation with them about targeted therapy. So give us an example of what goes through your head and how you then explain that to the patient about how you decide what's the approach that's right for them, how you choose in a general sense what the agent is, and then how you present that to the potential patient and the family.
Sure. And I trained under you, so I feel like I really learned from the best here. I really approach the patient with 2 underlying goals, and the first is to potentially maximize their survival, but hand in hand with that, I'd also like to maximize their quality of life. My personal belief is that very oftentimes entails participation in clinical trials. One of the challenges with the therapeutic state that we're in right now with renal cell is that although we have 7 FDA-approved targeted agents, we really only have 2 categories mechanistically of drugs, VEGF inhibitors and mTOR inhibitors. With clinical trials at our disposal, we oftentimes expand beyond that. We'll be talking soon about clinical trials of PD-1 inhibitors, MET inhibitors, and so on. And I often find that the toxicity profiles of those agents can be acceptable, if not better, than some of the existing drugs that are currently at our disposal. In terms of establishing prognosis, I don't think that that's evolved markedly over the years. Previously, we would apply the Motzer criteria or MSKCC criteria in the context of patients receiving immunotherapy. In the context of targeted therapy, those have now morphed into the PENG or IMDC criteria. Those are certainly helpful in risk stratifying patients into good, intermediate, or poor risk cohorts on the basis of factors such as their baseline hemoglobin, performance status, and so on. And certainly that may play a role in treatment allocation as well.
But do you find, for example, that although approaching the patient may be similar, your expectations in terms of benefit will be different based upon different prognostic variables that the patient presents, and then you can have a kind of a sense of what to expect in terms of the value of the therapy in that patient? So you're already making a judgment about how well they'll do or not do, independent of the toxicity?
That's a great point, and I certainly think that now that these prognostic factors have been embedded in the context of targeted therapies, we can do so in a much more precise fashion.
So, Dr. George, patients in front of you, previously untreated, metastatic disease, good or intermediate prognosis, or occasionally poor prognosis. How do you choose your first-line therapy?
So I try to stick to the evidence and based on the large phase 3 trials that we have. Majority of the patients who were enrolled in the sunitinib versus interferon trial were good or intermediate risk group, and so was the pazopanib trial, and so was the bevacizumab interferon trial. So those are the first best choices, but bevacizumab interferon is not used as much as the TKIs because of the ease of use and need to come back to clinic for infusions and also the need for multiple injections. So sunitinib or pazopanib are the first choices in that setting for intermediate or good risk group. But for poor risk patients, I try to use either temsirolimus or sunitinib as the first dose, as first drug to start.
Issues applied in Ecuador. Many nationalists metastatic renal cell carcinoma has evolved considerably in the past 10 years due to better understanding of the tumor biology. This development have the changed NRCC to a chronic progressive disease with several lines of treatment options. The introduction of several new targeted therapy, including immunotherapy, has improved median overall survival of approximately 1 year to 2 years or more years in NRCC. Conclusions. Renal cell carcinoma account for 2–3% of malignant neoplasms in adults. It results in incidence and decrease influences the development and systematic use of diagnostic imaging methods, ultrasound, CT, MRI, that allow early diagnosis in asymptomatic stage. The clinical presentation of kidney cancer and its metastatic disease is highly variable. Currently, the classic trial of lumbar pain, palpable mass, and metaturia only appears in 10% of patients, with the most frequently insulated clinical finding being hematuria. Thank you for watching this video.